Hey, let's talk about hemodialysis. Alright, hemodialysis. So in my last video I talked about end-stage renal disease, and these patients are no longer, or their kidneys are no longer able to control the amount of fluids in their bloodstream or to monitor their electrolytes such as potassium, magnesium, phosphorus. Feel free to watch that last video. It's in this playlist, or you can see it in my description below. Now, hemodialysis, this is, hemo refers to blood, and dialysis refers to, they're going to artificially have an artificial kidney, essentially, that's going to be doing the filtering and the monitoring of the blood, the electrolytes and the fluid levels. And so this is different than peritoneal dialysis, in which case hemodialysis, they're going to be pulling blood out of the patient and filtering it in a machine and putting it back in the patient. Peritoneal dialysis, a totally different story. We're not going to talk about that today. Hemodialysis, so you can see this, some patients do this typically 3 days a week, Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. Outpatient, they just drive to the clinic. Typically it lasts about 4 hours. Hemodialysis also can be performed in the hospitals, and there's some varieties. Where I work, we just do the typical 4-hour dialysis treatments, but they do have something called like a sled in ICUs, very critical patients that can't handle the effects on the body from being in dialysis with having blood sucked down and pushed back in, because they're very critical in the ICU. It'll be much slower, so instead of 4 hours, it'll be like 12 or continuous. We're going to talk about just regular old 4-hour dialysis on a med-surg floor. What do we do? So, preparation for these patients. Typically, they start dialysis first thing in the morning, and so they typically eat breakfast. You treat their insulin, or treat their blood sugars with insulin and stuff. Now, when it comes to the other meds, you're going to want to hold some. You're going to want to hold blood pressure meds. When I say that, I'm meaning antihypertensives. So the beta blockers and the calcium channel blockers, etc. Because you don't want to, they're going to be pulling fluid out of the patient, and so that may drop the patient's blood pressure. You want the drop in blood pressure to be to getting those excess fluids out, not artificially due to these medicines. Okay, antibiotics. When you give someone an antibiotic, it's floating around your bloodstream, getting where it needs to go. It's going to get sucked out in the dialysis machine, and so it's not going to be able to do any good. Just save those for after. Same thing with vitamins and medicines like for seizure, Keppra and stuff. They're just going to be sucked out. You're going to want to hold those, and you'll see here after, go ahead and give those meds, of course, after reassessing the patient. I say analgesics here, you might want to hold those. Check the patient's blood pressure. I typically just go straight and either ask the doctor or ask the dialysis nurse what their thoughts are about the analgesics. I don't want to give them a big dose of morphine that may drop their blood pressure, then them go in and have it drop more. Okay, also you want to check your dialysis site. Now there's 3 sites here. An IJ is a temporary dialysis site that's in the neck, typically put in by a pulmonologist or a nephrologist. And it's just going to look like an IV in the neck. We don't use these for medicines, we don't use these for labs. It's just going to be 2 tubes coming out of the patient's neck, intrajugular. Okay? This is temporary. Typically this will be if the patient's only needing dialysis for a short amount of time, or put this in real quick until they get a perm cath. Perm cath, they go in and do a tunneled catheter through the chest into a larger artery. Now this is semi-permanent. It could be for 6 months, or it could be really indefinitely, but it's that kind of high risk for infection because it's a port going straight into the chest. A more permanent option is a fistula or a graft, which will be found in the patient's arm typically. Sometimes they do it in the legs. It depends on the vascular surgeon who puts it in. So if you do an IG or perm cath, you just want to make sure that it's clean, dry, and intact. You don't need to do any flushing or anything. They're going to do that when they get there. If they have a fistula or a graft, you want to check for bruit and thrill. So you'll see the big bulging vein up their arm, and so you want to make sure you put your fingers on it. You'll feel the blood swishing through there, not just a pulse. That pulse doesn't mean anything. You want to feel the flushing through there, and you want to make sure you hear. Take your stethoscope and listen to it, and you'll feel, or you hear, whoosh, whoosh. You want to make sure those are there. If they're not there, then it may be a sign that it's not going to work right in dialysis. With these arms, you don't want to start IVs in the arm or do blood pressures in the arm, because you don't want to damage that vein. Okay? So during dialysis, you're going to want to, the dialysis nurse is going to be the main one monitoring them, but your job is basically give any meds or blood and help and assist to monitor the vitals. Okay? After dialysis, they're going to come out 1 or 2 o'clock. You want to go ahead and give them their meal, and any of those meds that you held, reassess them, and if they're good to have them, that's when you'd be given those meds. So this is dialysis in a nutshell. And feel free to like me on Facebook or comment if you have any more questions, or comment on Facebook if you have any more questions about dialysis, what to hold, what to assess for.